Thank you so much for the introduction. I think I don't have the answer, even despite your offer of $1 million. But at least we can try and journey through this. It is the end of the day. And I thank Dr. Tariq for putting me at the end of the day. Whatever did I do wrong? So the question, as a pediatric neurologist, we often see these patients, and this was actually supposed to complement Dr. Huda Sadek and other colleagues who couldn't sadly talk today. So I don't by no means define autism, or I'm an expert. But we often, as my colleagues in pediatric neurologists will agree, we often do see these children as a crossover in epilepsy clinic. We see them also, we see many autistic features. We also see them sometimes firsthand. And we always get the question, as a neurologist, can you explain? And we usually look autistic in the other direction. And we don't have a scan or anything else to show. So we want to know what do we mean by nature or nurture? What are the different theories? Take a look at history and any potential future strategies and what treatments there could be, as well as perhaps an approach to testing. So by nature, we mean innate behaviors, which are inherently are genetic, and nurture are usually as a result of experience. So autism was first described by this chap, Leo Kanner. And then there was a gentleman who came along a few years after who attributed autism to a lack of maternal warmth. So he blamed the mother, and also coined this term called the refrigerator mother, who is shows a very cold, shows no emotion. But this was subsequently refuted by Dr. Rimland, whose own son had autism, and subsequently Leo Kanner apologized to parents for his misguiding thoughts. We know that many children who are exposed to severe trauma or deprivation, and there are many at this time in the world, can exhibit autistic features. Also, rhesus monkeys who were exposed to early maternal deprivation showed a high percentage of autistic features. When I grew up, there was this tragedy within Europe of Romanian orphanages being severely neglected, and many of these children were adopted in the UK, and a high percentage of these children were showing autistic features, more so than you might experience. We also know that many congenitally blind children exhibit autistic type features in how they present, and it's certainly many children who have visual impairment do have very prominent autistic features. We also know that many children with autism, it's very obvious that they show poor eye contact. They tend not to look at faces. And following on from this theory that visual deprivation at a critical period during development may lead to long-term visual impairment, similarly, there is a theory that social deprivation may underlie many of the developmental and behavioral difficulties. And again, this is just a theory. But there has been further studies of face processing deficits seen in children and adults with autism using functional studies. There are parts of the brain, particularly the inferolateral temporal and occipital cortex, known as the fusiform area, where there is response to social faces. You get activation because of looking at faces, that be strangers' faces, familiar faces. And this study, this just illustrates the fusiform area. And this study shows the difference between a normal brain and an autistic brain. And when they were exposed to familiar faces, you get significant activation in this fusiform area in normal subjects, as well as to stranger faces. In the autistic brain, there is less activation, particularly to strangers' faces, but there is some activation, but less so in the cingulate gyrus and other areas which you get in normal subjects. So there is less response to faces, but particularly stranger faces. Again, this illustrates this lack of activation in response to faces, and perhaps a reason why they don't seem to respond to facial gestures. Another theory supports that whether oxytocin, as we know, it has many different roles, whether a lack of peripheral oxytocin may contribute to a lack of social and facial responsiveness. And this shows that if you administer oxytocin to a normal subject, you get increased activation in these social areas of the brain. And many parents have, and adults have used oxytocin. So it has been abused in some cases in people trying to get, who have social anxieties. So many parents have acquired intranasal oxytocin to try and see if it improves autistic behaviors. And there were some theories along this line, but this trial in the New England Journal of Medicine showed that there wasn't any statistically significant difference in a group of 277 children who were randomized to either get intranasal oxytocin or placebo. So this shows that this probably dispels this theory, but mutations in the oxytocin receptor do account for some children displaying autistic features. Another theory, which many people would have heard of a few years back in 2015, which came from Professor Cohen in Cambridge, was this prenatal exposure to elevated testosterone. We know that more males are exposed, almost 4 times as more display autistic features as compared to females. There's a higher incidence in males, higher incidence in, I would say, male physicians, and I'm sure many colleagues will agree. But there is an increased incidence in children of mothers who had polycystic ovarian, as well as there is an association in a systematic review of mothers with increasing maternal age, as well as weight. And again, this is an association rather than a cause. So when they compared, during the study, they looked at the amniotic fluid. This was a very comprehensive study and follow-up study of children who subsequently developed either pervasive developmental disorder, Asperger's, or childhood autism. And it showed that there was an elevated amount of androgens, testosterone, progesterone, cortisol in children, as you can see, as compared to normal controls. What came of this series is not known. Subsequently, there hasn't been many publications, and it's not known how this comes about and whether it's the sole factor responsible for autism. So what about nature? And by nature, we mean genetics. We know from early studies that monozygotic twins, there's a 60% concordance. Although between monozygotic twins, they display different autistic features, which is an interesting observation. Dizygotic, the incidence is anything between 5 to 12% concordance. There is a sibling risk that many people will know of, around 20%, and if you have 2 or more, it can go up to 33%. We know, and we'll talk about briefly, about genes which encode for neuronal cell adhesion molecules, migration, neurotransmitters, which can account for a number of children with autism. And we also know about single gene disorders which can account for autism, such as Fragile X, tuberous sclerosis. So is autism genetic? If it was as simple as doing a test, it'd be quite easy. But there is genetic as well as environmental and epigenetic factors. I think we are moving forward in terms of genetics. The big unknown and the next field of research will be in epigenetics, about how environment influences gene expression through methylation, through other factors. At the moment, around 15 to 40% of individuals autistic will have an identifiable genetic cause, but the vast majority will have no known genetic etiology, although that's likely to increase with whole genome sequencing. Many colleagues who work with an epilepsy, and this is just from my own experience of what comes to mind when I think about epilepsy and autism. Certainly Rett's in females displaying autistic features, CDKL5 and RXN1, the sodium channel mutations, STXBP1, and probably a few more come to mind, and I'm sure people can also think of others who have very prominent autistic features as well as epilepsy. And many of these, like SCN8A and other channelopathies, are amenable to some disease modifying and probable gene therapy in the near future. So autism spectrum is highly genetically heterogeneous. It can be both inherited, and although the vast majority are thought to occur de novo. As I mentioned earlier, only a handful are due to monogenic causes. There have been 2 or 3 systematic reviews, as well as an umbrella review. And again, it doesn't come up with a simple answer. They have come up with the fact that there are many genes which are involved in synapse, in neurotransmission, and chromatin remodeling pathways, which are thought to be responsible. And again, this just shows that when you analyze the results, that around 50% have inherited common variants. We know that copy number variations within 16p12 and 15q can be associated with autism. But there are other gene copy number variations which can be responsible, as well as single nucleotide variations within SHANK, NRXN, as I've alluded to earlier, and CNTN. It's not, there are so many which are associated that it's not a simple one answer. But we know that synapse-related genes are thought to be responsible, and we know that autistic brains, they're often larger volumetric studies, and I've not gone into that. And whether synaptic pruning and connection forming after myelination may be responsible is a possible theory. Again, thinking about the different in tuberous sclerosis, where mTOR pathways are affected, and other gene mutations where synaptic functions are affected. And this kind of gives an overview of the possible different genes and how they may be linked to the development of autism. This is looking at this, again, the synapse and neurotransmitter metabolism, transport, synapse, and as well as subsequent effect. All these genes are maybe exhibit autistic features. So I think there is a complex mix between epigenetics, environment, as well as other factors which then lead to gene expression. And it's not fully known why this happens in some children and not others. I just wanted to briefly talk about Rett syndrome, which is an interesting neurodevelopmental and neurological condition. And we see many children in the epilepsy clinic with Rett syndrome. It starts off with relatively normal development, with then developmental stagnation, regression in language and motor skills, and prominent hand-wringing features, teeth grinding, and acquired microcephaly, small hands and feet. And 80% are due to de novo pathogenic variants in MECP2. In terms of this, and given that this is, many of these children show very prominent autistic features, there has been now a drug which has gone into phase 3 trial. The full results of this haven't been published. This is known as the Lavender trial, which looked at this nucleotide, trofinetide, which was used versus placebo over a 12-week period to see. And what they measured was, this is the Rett scoring behavioral questionnaire and the caregiver's global impression scale. And they looked at this at baseline, then at 2, 6, and 12 weeks. And I don't have this isn't fully published as yet, but there is some initial results from this, and this is going to FDA approval for both Rett's as well as Fragile X syndrome. And this showed that the children who were treated with trofinide showed an improvement in their mood, breathing problems, hand behavior, face movements, body rock, many of the things that we recognize within autism. And this was statistically significant. And this is why this has now gone to FDA approval within the States to be used. And this now has gone to the Daffodil trial, which is the next phase of this, which is an open label stage of this study. So it's important to look for a genetic etiology, and we know the reasons why. And if you can classify, there may be future treatments which may be important to identify. So in terms of how do we know, alluding to my last speaker, we look for urocutaneous stigmata, we look for dysmorphic features. If we have seizures, we definitely will do genetic analysis, as many channelopathies can be responsible for autism and epilepsy. And I think chromosomal microarray, given that around 1% have copy number variations within 16p or 15q as well, it's what's still using as the first line in these children. And sometimes you will come across variants of unknown significance, and parental testing is then important. But having a geneticist who understands and is able to counsel is important. But whole exome sequencing, and there are now dedicated panels of around 350 to 400 genes, which are often linked to autism and intellectual disability, which are now available on whole exome sequencing, may be able to shed light to parents. And again, genetic testing is highly variable here within the UAE, but there are private panels now which are available for a few $100s, which can test for autism predisposition genes for some of the genes that we've mentioned in our talk. Again, it's worth knowing, is this isolated or is there additional symptoms? And that will guide how you test in terms of genetics. This is just a reminder slide to remember about Fragile X, and testing for this condition is still important, isn't it? So the important take-home messages are that autism treatment, there is behavioral therapy, there is speech therapy, but I think the future will be, if you're able to identify factors such as the REPS model, which is a great model, and Fragile X. Both of these, there are now active trials for nucleotides which are thought to be disease modifying. So a better understanding of the autism disease pathogenesis will help us to better treat this condition. We don't have the $1 million or dirham answer yet, but it's likely that there is a complex interplay between epigenetics and genetics. Much like in IVF, DNA methylation, depending on the quality of the medium and things, there is an association with subsequent developmental and pervasive developmental disorder. It is thought that there is some unknown here that we're clearly missing. We should, I think, in terms of autism, we should, evaluate them neurologically. Certainly, there are, I can think of many conditions that we picked up sometimes in children who are otherwise labeled autistic, such as Sanfilippo with regression. Certainly, a recent leukodystrophy presented as prominent autistic features, as well as Duchenne's, alluding to our earlier, they may just present with significant autistic features with late walking. And conceptualization of genetic phenotypes with knowing the gene and then reverse phenotyping and using functional studies such as MRI may lead to a better understanding. And new disease-modifying agents, as we've talked about, such as in Rett's and Fragile X, may offer potential treatments and cures in the future. Thank you.